Morning, Jim.
Good morning.
I just want to take this opportunity to ask you some questions about your time here at MCV and now VCU, and what it was like and what things you changed. So tell me about the time when, how it was when you first came here. What brought you here?
I started medical school here in 1968, and the reason I came here was during World War II. My father served in the 45th General Hospital, which was the hospital made up of people from the Medical College of Virginia, along with some draftees to fill in different positions. My father really liked the people he worked with. I came down for an interview, liked the people I saw, and got accepted and came here in August of 1968.
So medical school, and then where did you do your surgical residence?
I did my surgical residency here also. During my residency for 2 years, I was a clinical associate in the National Cancer Institute working in the surgery branch. Came back, finished my residency, and was offered a position on faculty early in my chief resident year.
Did you grow up in Richmond, Jim?
I grew up in northern New Jersey.
Okay. But your dad was a part of the 45th Hospital, which included members from MCV? Is that how you...
It was made up primarily of people from MCV.
Okay.
And my father was an optometrist, and he was drafted and served in the eye unit in that hospital.
Where was that hospital based at World War II?
They started out in Fort Lee, and in 1943 they were transferred to North Africa, where they spent time at Rabat. They were there for about 8 months, then went to Naples, Italy, spent almost a year there, and then finished World War II in Bari, which is across on the east coast of Italy.
Have you traveled to any of those places to see anything remains of the hospital, or it's all mobile units that probably were all kind of...
They were not mobile units. This was a base hospital.
Base, okay.
I've been to Naples, I've been to Morocco, but not Rabat, and there's nothing that remains of any of those units.
So that story has not been written, has it?
Yes, there's a book.
Okay.
Just entitled 45th General Hospital, and it goes through the formation of the unit, the training, where they were, what kinds of things they saw and did, what they did in their free time. It's a very interesting book.
There were other members of the department who served in World War II, right? The stone burner, and there's a little plaque I see always on the West Hospital on the floor.
Yeah, most of those people actually were not on the faculty at that time. They'd gone to medical school here. There were a lot of part-time physicians because MCV had very few full-time surgeons. There were some other people, Kinlow Nelson, who was later the Dean of Medicine here, served as the executive officer of the unit. And my father actually thought he was the commanding officer because he talked to Kinlow more than anybody else, but Kinlow was the executive officer. He was actually overseas only a year because he developed a case of tuberculosis. And then came back here, was in the Department of Medicine, then became dean, and actually was a dean when I was a medical student.
Okay.
Other people include W.T. Thompson, who was later the chairman of medicine here, and then a number of part-time people. There was a thoracic surgeon named Buck Cherry who had a clinical appointment here. His son later became a vascular surgeon and was the Mayo Clinic and then at the University of Virginia.
Oh, so Ken Cherry?
Yes.
Yeah, okay. Wow, I didn't know the connections were that. That's pretty impressive. So when you came here as a medical student, how was it like? The medical school, the faculty, the hospital?
It was very much a clinical institution. There was no main hospital. There was no gateway building. Sanger Hall was fairly new. The Egyptian building, of course, was here.
Yeah.
And what we primarily learned was clinical medicine. And we had the reputation then, much like now, of training very good clinically oriented medical students. There was research going on, especially in the Department of Surgery. Dr. Hume had multiple large grants. I participated in some research in the Department of Surgery throughout medical school, and even as a junior resident, although that was certainly a lot more difficult once I graduated medical school. But there's a building called the Strauss Building near the library, which primarily was used by the Department of Surgery for research in those days. There was also large animal work being done in Sanger Hall, and Dr. Hume did that, Dr. Newsom and others, Dr. Lauer, of course, did a lot of transplant work there too.
So how did you have a chance to work with Hume directly in the lab or clinically?
I worked with Hume clinically, and in those days I was interested in going to transplant. The person I worked with primarily, who was my mentor, starting my second year of medical school, was Jim Pierce. And Jim was a junior transplant attending who was an MD PhD from the University of Minnesota. And we did work looking at ways to boost immunity to different things. And then I moved from there to working still with Jim on ways to try and prevent transplant rejection. I started working with H.M. Lee in those days, looking at primarily vitamin A and whether or not that would affect tumor or transplant immunity, because we knew it changed wound healing. And the question was whether it affected transplant immunity also. With Dr. Hume, I primarily worked in the clinic. I took an elective on the transplant service as a fourth-year medical student. Worked with him there. I also worked with him when I was seeing patients on the floor, some of the vascular patients. And then, since I was interested in transplant, I worked with Dr. Hume on the baboon perfusions toward the end, when he would have patients in liver failure and hook the patient up to a baboon liver, which was removed over in Sanger Hall and then brought over to the clinical research unit, and we would hook an AV shunt from the patient to the liver and try to quote, cleanse, unquote, the patient's blood.
Was there anything published from that experience?
I don't know. I was not a part of any publications. We had one patient who actually woke up from hepatic encephalopathy. He was a surgeon from Howard who had developed hepatitis. And he woke up and then developed an overwhelming fungal septicemia and died from that before he could be discharged. Other patients had improvement of liver functions, but it was an extremely time-intensive, labor-intensive struggle to keep those patients alive and perfuse livers. It initially started out, before I was involved, with the whole baboon, but then they developed a technique just to use the liver. And it required an incredible amount of time and an incredible number of personnel. So I think it was a little bit before Dr. Hume died that stopped.
So clinical liver transplantation at that point had not reached wide applicability, because Starzl was working on it in Colorado at that time, right?
We had done two here.
Okay.
The second one was done in 1970.
Okay.
And was successful. Although the patient died a little over a year later, because it turned out the transplanted liver I shouldn't say the transplant, the liver that was removed from the recipient had cancer in it, and multiple frozen sections have been negative, but the final pathology showed hepatocellular carcinoma. And the patient died a little over a year later with cancer everywhere in his body except in the transplanted liver.
Hmm. Wow. I didn't know that the liver transplant was that. So Starzl was just pioneering it. So
Correct.
we probably were in the same pioneering.
There was a huge competition between Starzl and Hume.
Okay. How was Hume like as a person to work with?
Hume was extraordinarily charismatic, easily the most charismatic person I've ever met in my life. If he said, jump over Niagara Falls, everybody would have done it. He was extremely smart. He thought he knew everything, and oftentimes would quote articles and everybody would be dumbfounded, although sometimes if you looked for the article, it didn't exist. He was very careful clinically, had very good judgment, but technically in the operating room was mediocre. He was slow and meticulous. His patients did do very well. He had many other interests, including sports, and he used to go to local hockey games and was the loudest person in the audience.
I know that Walter was telling me that he and Hume played against each other when they were in college. I
Correct.
can't remember whether it was in college or medical school, but I think they were on the football teams from different.
That's correct. Hume was one of the great partiers of all time, and you probably heard some of those stories. But the Department of Surgery would have parties and then be banned permanently from wherever the party was held. One was on the 8th floor of Sanger Hall, one was the Valentine Museum, and those locations were trashed. Dr. Hume loved the residents. He would do anything for the residents. He owned a small island in the Bahamas and would fly his private plane down there with several residents on the plane. He was unfortunately not a real careful pilot, and that's what ultimately led to his demise. But there were several residents whose wives would say, "I'll divorce you if you ever go in a plane with him." But he had parties at his farm in Goochland. He would have New Year's Eve parties. He was a real partier. Dr. Hume was also a late night person, and it was very common where he would show up on the floor at 3 or 4 o'clock in the morning making his evening rounds, quote unquote, and he'd walk up to a medical student and say, "Who are you?" And he'd say, "You want to learn something? Follow me." And I mean, everybody just loved him, and large numbers of students went into surgery because of their exposure to him.
That's awesome. Is there any video footages of Hume left? Because I've not seen meetings or the archive.
I don't know. I don't think I've ever seen any.
I don't think there are any video footages of the parties.
No, I don't think any of those exist. And you have to remember, back in those days, the cameras were huge.
Right,
And it was all film.
right.
So it wasn't like someone had a cell phone and surreptitiously took pictures.
I have to ask Jody in the library if she has any video footage. I saw a recent video footage of Alfred Blaylock from Hopkins. It was in the old, they took the old videos and digitalized them. I'm certain there's something, these OR cases and stuff.
There might be something around somewhere. I've met with Mrs. Hume and the children before Mrs. Hume died, and they were totally clueless as to what he did down here. And I would tell them stories of Dr. Hume, and they would just had almost shell-shocked expressions on their faces because he never brought any of that home with him.
Maybe there are even home movies we can digitalize that show him as a person.
Lauren Moore has the contact information with the children.
Okay. So I'll follow up with that. So was your exposure to Hume was the why you went into surgery? along with Dr. Pierce?
No, actually I started out wanting to go into orthopedic surgery.
Okay.
When I was young, I had a lot of back operations, and I had a very influential orthopedist who took care of me. He had been president of the American Orthopedic Society or Academy, whatever it's called, and he also was a very charismatic person. So when I started medical school, I actually did research on fracture healing. And to be honest, I was sort of bored by it. And then because of the institution and the recent starting of cardiac transplants and learning more about Dick Lauer and David
Right.
Hume and H.M. Lee, etc., I sought out Jim Pierce, and we developed a program where my second year of medical school I started doing immunology research, and then that progressed, and my first few publications actually were transplant.
Okay. Was Harry Baer in the lab with you? Harry said he worked in the immunology lab as a high school student. And then
Correct. He at that time, I believe he was in college. I think
College,
he was in the lab before I was.
So then, when did you come on faculty?
1978.
78. How was the department then when you joined it?
It was a lot smaller. Transplant was 2 people. Orthopedics was either 1 or 2 at that time. I think just they were down to 1. Orthopedics was a division in the Department of Surgery. 1 faculty member, 0 beds. So the person who was chair of orthopedics, as well as being the only Indian, had to beg, borrow, and steal beds when patients needed to be operated on. Surgical oncology had 3 people, had Walter Lawrence, Joe Turs, and Roger King. And there were several part-time people here. I'm trying to think what the other divisions had. Cardiac had Dick Lauer and Louis Bosher.
I think St. Petrie had maybe just come back from Vietnam, or he was not.
St. Peter was still in the lab then. He and I were in the lab together
Okay.
for a while. Jim Brooks, of course, was doing the
Thoracic.
the thoracic. Arnold Salzberg had just left. He was gone for about 2 years. And a guy named Isidore Shanfield was the pediatric surgeon. It was a vascular and transplant service, so we had no separate vascular surgeons. H.M. Lee and David Hume did the vast majority of the vascular. A guy named Jim Wolfe was a general surgeon. He also was the head of surgery at the VA. I'm trying to remember who else. In the lab, there was a guy named Harry Ohanian who was succeeded, and I worked with Harry, and he was succeeded by Alan Kaplan, who later went to the University of Kentucky, and then Mahana Kumar, who was a superb immunologist.
Right. But was Bob Diegelman was doing wound healing research at the time? Or?
Bob may have come, he came a couple years later. Kel Cohen actually started the same time I started my internship. So Kel started the lab. Bob Diegelman came on board a little bit later. I can't remember the exact year. Dawson Theagaraj was a plastic surgeon, came in, I believe, around 75 or 6, something like that. And then later, Austin Meerhoff and Wendell Merritt came on board.
Who was the chair at that time when you?
Kel Cohen.
Kel was chair of surgery?
Oh, all surgery? David Hume.
Hume was, okay.
Yeah.
When did Hume pass away?
May 19th, 1973.
Okay.
And then Walter Lawrence was the interim chair for a little over a year, and then Laser Greenfield was named chair.
Okay. And Laser was the chair here for a while, right?
Laser was the chair for 12 years.
Okay. How was Laser as a faculty and as a chair?
Laser was a very different person than David Hume. Very, very smart, and much more business-like. And of course, that's what was needed in those days. As medicine became more business-like, you needed somebody like that. So I think Laser was a very good choice. He ruffled some feathers initially. Dick Lauer threatened to leave. Louis Bosher did leave, which is probably more because of Dick than it was Laser.
Right.
He recruited faculty. He was instrumental in getting several research grants. Laser was a cardiac surgeon, but had such bad results, to be blunt, that he gave up cardiac surgery and did vascular and some thoracic. And he was an excellent vascular surgeon. He left in 1986 primarily because he and the new dean disagreed about some things, and the dean would not relent, and Laser left to become the chair at University of Michigan.
Who was the dean at that time?
Steve Ayers. And Steve was from the University of St. Louis, or St. Louis University, and he was not particularly effective.
How long was he the dean?
I want to say 4 or 5 years, but I might be wrong.
So it's interesting. So I was just looking at some slides on NIH funding and the change. In 1996, there was an inflection. We were on the trajectory up all the way to 86, 87. And around 86, 87, our NIH funding plateaued and it started dropping. And that related to the chair was change in chairs of surgery and the deanship, I think. Because those were the two big changes that occurred then.
Correct.
Then I think we never caught up after that. UVA, it's us and UVA were going neck to neck, and UVA then just kind of crossed us at that point. So,
Well, the institution has always had monetary problems, and UVA was always the favored son in the legislature, so that's part of it. Our facilities were in sad need of upgrading, and until we could get enough money from the state,
right,
that didn't happen.
right,
In fact, I put a big part of that on the presidency of the university, because until Gene Trani was president, there was very little infrastructure
Right.
developed on this campus. And then when Trani became president, I guess you could call it the age of infrastructure development on the
Right.
two campuses.
right,
And under him, there were great strides forward.
right. And I think it's continued now with Mike, both on this campus as well as the other campus.
I
Like,
totally
awesome.
agree. Totally agree.
Huge amount of growth. So when did you become the division chair?
I was never division chair.
Never division chair, okay.
No, I was, I had a research lab
Okay,
funded by NIH and the American Cancer Society. Had to give that up after about 8 or 10 years, just because I was so busy clinically that I didn't have time to
right,
run the lab. People in my lab, several of them became department chairs later. So it was a productive lab. Then I continued to be very busy clinically, and in 2002 I was made vice chair of the department by Ron Merrill. And about 8 months later I was named department chair.
okay, good, okay. So in terms of surgical oncology, Jim, where do you see the future of surgical oncology? Where do you think we should focus on? I'm asking you this as a new chair in some ways. As what should we focus on? As
You've been
we
chair
go?
for more than 5 years, so you're not exactly new.
So that's not a new, okay.
But I think there's an old saying that I know you know, and there was a Spanish philosopher named Santayana who said, "Those who forget the past are doomed to repeat it."
Right,
So I think if you look back at surgical oncology, or look back at cancer care, it was done by general surgeons.
right,
And it was only when surgeons specialized in the care of cancer patients
right.
that the care really improved, operations were devised, and morbidity and mortality rates decreased. And then research became more and more important in the 70s, 80s, 90s. And I remember very well, back in the early 80s, I was a junior faculty member, and the head of the National Cancer Institute, Vince DeVita, came here to open up our new cancer center building, something Walter Lawrence and the Massey family had developed. Well, I knew Vince very well from my days at NIH. He had been a junior attending when I was at the NIH, and he had a meteoric rise to become head of the National Cancer Institute. So I was assigned to show him around. So I remember this was early spring, and a couple months earlier he had been quoted as saying that with the development, or with the discovery of oncogenes, there would be no need for cancer surgery by the end of that year. I believe it was 83, might have been 82. So, in my own inimitable way, I said, "Vince, you really didn't say that, did you?" He said, "Oh yes, I really believe that by the end of this year there will be no need to ever operate on a patient with cancer." Now if you say the word oncogene to most people, they wonder what the heck it is you're talking about. So I think we've had a lot of potential cures of cancer. There's certainly nowadays personalized medicine, which has promise, but until some of this is proven in scientifically performed studies, I think surgical care of cancer patients is going to be the mainstay of cancer treatment.
Right.
And I realize I'm a little skeptical of some of these advances, but I think it's borne on the fact that a lot of these very highly touted treatments have not panned out.
Right, and recently there was a study that I don't remember the name of the study, where they showed that if you resect early breast cancer and I don't know if it's the RNA or some profile is favorable, you may not need any more chemotherapy on those patients.
Correct.
Because the chemotherapy does carry up to 50% risk of cardiotoxicity in some.
Well, it depends which drugs you use.
Right.
Yeah, and that's no surprise, because even if you look at patients with breast cancer overall, or colon cancer, or almost any cancer, the cancers that have been shown to be improved by additional therapy after surgery, chemotherapy, the benefit is very small. And it's only statistically significant because for a lot of these diseases, the numbers of patients is so high.
Mm-hmm.
So you get into what you're alluding to, and that is, does the risk overwhelm the benefit?
Right.
And that's something that people don't look at. They just look at survival.
Right. You know, where people specialize in hepatobiliary, pancreas, colon rectal, GI. How do you envision the training of surgical oncology to be?
I think fewer and fewer places will be able to train surgical oncologists. I think the ones that are best suited to do that are those with large numbers of cancer patients, and they may have different subspecialty groups within that cancer cancer clinic, that cancer division, who could train people for like I said, colorectal, hepatobiliary, head and neck,
Right.
endocrine, etc. The difference between, in my opinion, a surgical oncologist and a hepatobiliary surgeon or a colorectal surgeon, etc., is that a surgical oncologist is trained to take care of the whole patient, has much better understanding of the effects of chemotherapy, immunotherapy, radiotherapy, than someone who more narrowly trains in that super subspecialty.
Right. But do you think in our training program, because so give you an example, you did a lot of head and neck cancer in your training, but almost now most surgical training programs that's fall into the domain of ENT head and neck surgeons, we no longer perform much head and neck surgery other than endocrine, thyroid and parathyroid. How do we make sure that we have a broad training, but then perhaps when they go out to practice, they may choose to practice endocrine surgery or breast surgery or hepatobiliary, pancreatic or colorectal specifically? I think that's the challenge that I'm facing, is how do we create this training opportunity, which may be very different than what they would go out and practice.
Well, I think that someone has to be exposed to everything, and it's easier said than done, which
Right.
is what you're saying, especially for head and neck.
Right.
Because ENT has pretty much taken over
Right.
head and neck in this country. When I retired, there were only a couple of general surgical oncologists who had any significant volume of head and neck cancer.
Right.
And that's because ENT refers to ENT, and primary care says, oh, it's a head and neck problem, refer to ENT. So they pretty much captured it. Also, even though almost all advances in head and neck cancer surgery were done by general surgeons, a lot of general surgeons just are intimidated by head and neck.
Right.
They lose big wounds and
Right.
a lot of rehabilitation, and you don't want someone going around, oh, who did that to you? And it's Dr. XYZ. Well, I'm never going to him
Mhm.
or her. So head and neck may be a little bit of an outlier, but
Right.
in terms of other things, if the resident can get a good exposure to all the different areas of surgery, I think that person, when he or she leaves, is then equipped to build on that to either continue, especially in a smaller town, a diverse practice, or it may be that things sort of devolve on that person, and instead of him or her doing everything, all of a sudden they're doing a limited amount of stuff. But I think the big thing is a diverse training, a broad training. And I'll give you an example. When I finished my residency, it was really before the days of much fellowship training. So I was sort of a junior faculty member, fellow at the same time. I had done a lot of oncology cases when I was at NIH, but there were certainly many things I hadn't done, and I had some senior people who could mentor me until I was comfortable. Well, the first 8 or 10 years I was on the faculty, almost all I did was head and neck cancer.
Mm.
And then as that started decreasing, people started referring more GI cancers to me. Well, I had good surgical training, I knew how to do GI cancers. And then as that, I don't really want to say tapered, but what happened when I became department chair, I had to find more time for the administrative work, and I pretty much lateraled most of the GI cancers to one of my faculty members. And what I got then was mainly melanomas, sarcomas, and those kept increasing. So because of the broad general surgical training I had had and keeping up on the literature in my field, I knew what was current, what was appropriate treatment, and we were able to give patients good care, despite the fact I hadn't been doing a lot of it the entire time.
Okay. What advice would you have for a chair of surgery?
be adaptable, because the times are changing probably more rapidly now than they were even when I was chairman a few years ago. A lot of it is driven by changes in what the federal government demands, requires, oftentimes without any evidence that's beneficial. As nicely demonstrated in the recent report showing that electronic medical records cost a lot of money and don't do anything for patient care or for doctors' well-being, because so much more time is required. But it's mandated. There's not a whole lot of choice yet. I think the other thing that's important is that the people who are coming into medicine now are a lot different than they were 20 years ago or 30 years ago. They have a sense of entitlement. So they require more holding of hands or gentleness than maybe people used to get in the past. Doesn't mean they're not going to be good physicians and good surgeons, but they just have to be approached differently. So being adaptable to changes in the culture, both administrative, bureaucratic culture, as well as the people who are coming up, I think it is important. And then it's sort of an age-old requirement of being a good chair, and that is being supportive of faculty and residents in terms of ideas. And a lot of good ideas were scorned initially, and then they turned out to be really good ideas. And I think those kinds of things would stand anybody in good stead.
What was the most enjoyable thing during your time here as faculty and then as senior faculty?
Well, that's easy. Seeing people come in as interns who didn't know much, couldn't do much, and look at them finish as surgeons and feel confident that they could go out and take care of patients and do a good job. And then the feedback when people from here would go to other institutions was always great, and it made me feel good that we were doing something right here.
Great. Jim, thank you so much. And thank you personally for your support and guidance.
Thank you, Vic. Continued good luck.
Yeah, thank you.